Okay, we're at the top of the hour. Welcome, everyone, to ASJ GEMS Global Educational Meetings. I'm your moderator, Phaedra, and I'm here with the one and only Dr. Jeffrey Kenkel from UT Southwestern, and also the editor-in-chief of Aesthetic Surgery Journal. Jeff, over to you.
Great. Thanks, phaedra. And thanks so much for your ongoing support of this educational event. Let's just say, I think it's been going on now for over 5 years, and it's just a wonderful opportunity to share really international education. So thank you all for taking the time to join us. I'm going to cover injectables, kind of where I am personally. We're going to talk a little bit about some technique. I'm not going to show a lot of before and afters. Then I'll talk to you a little bit about my incorporation of ultrasound into my practice and what my thoughts are on it. And then we'll kind of briefly touch on a 10-year review that we've submitted and got accepted to open forum that should be in print here or online here shortly. And then finish up with some complications, some personal ones that I've had, and then just some other issues that have been published. If anybody has any questions, we will definitely do a Q&A towards the end, but if there's something more urgent, I'm happy to stop and answer any. Okay, there we go. So I do a fair amount of research with devices. I don't think anything that I do will have any impact on this presentation today. As Phaedra said, I am the editor of ASJ. And this talk will be largely level 3 through 5 evidence-based medicine. It's a lot of personal experience. So just a plug for ASJ. We now have an impact factor of 3. 10% of the papers that we had published last year were level 1 and level 2 studies. So we think that's really a great sign of how important ASJ is in the aesthetic arena. We are trying to do things a little bit differently and innovating. We had our first call for papers in cosmetic medicine and have had almost 100 submissions to that. So it's been an amazing response. And then I'll educate you a little bit about how you may be able to purchase open access through your institution. Our turnaround time for first decision is really, it's the lowest it's ever been. It's 11 days. So that's, the industry standard is about 30 days. So you really hear back from our review process fairly fast. In our top sections, it kind of varies from year to year. I think cosmetic medicine now has been leading the way, followed by aesthetic breast surgery for some time. This was our top read and cited paper last year. It was on GLP-1 agonists. And we're seeing more and more submissions on that. Not only the impact that it has on weight loss, but the effect that it can have on postoperative recovery as well. So you'll see more of those published in both of our journals. Read and publish is something that we're really exploring further. You can use this QR code to see if your institution is on a read and publish agreement with our publisher, OUP. I know here at UT Southwestern, we're working towards getting an agreement with that as well. So that's really nice if you want to have open access for your paper that was accepted on ASJ, or even to help cover some of the costs on open forum. So speaking of open forum, under the direction of Al Ali, it's got its first impact factor back in October of 1.6. We've seen just a steady exponential rise in the submissions, and it has a decent acceptance rate. Our team really works hard to get these papers ready for publication. I think we're looking for smaller studies, perhaps some preliminary studies that people are doing. Video content, I think case reports, these are all things that are going to be amenable to open forum. So if you have those types of studies, please look to open forum for publication. And then as one of the perks, our team really helps you design some of these visual abstracts, which are great for presentations and certainly for social media and online. So these are kind of a nice little plus that you get when you submit something to open forum. These were the top cited and top read papers in open forum. One of them on AI, which is still probably, we're getting tons of submissions on AI, and just a field that's changing almost every day. So let's get into the meat of the whole thing. I had a few students that helped me with our 10-year review, and I just wanted to make sure that I gave them credit for all the hard work that they did. So we all know that when we're bringing injectables, at least to the US market, the FDA approval really requires pretty rigorous standards, and most of these studies are going to be level 1 studies that they're submitting for FDA approval. So here's kind of where we are in the US. I tried to list the different things, the different areas that we're going to be treating and the different products that we have. Um, I pretty much use all the different products. I certainly have my preferences, but I think the great thing about injectables in the US is we're seeing more and more products being introduced. Now, it's nowhere similar to what we have in Europe or in South America or whatnot, but I think we are getting more and more opportunities and options, which I think is great for the physicians as well as the patients. Well, how do you determine which product to use? Well, some of it may be on the local rep and the relationship that you have with them. Some companies offer bundling opportunities with products, which help cut costs. We like to have a lot of diversity, but the more diversity you have, the more overhead you have. I know the nurses told me just yesterday that we have one product that we have 18 boxes that are going to expire at the end of the month, and that's a pretty significant loss. So you want to try to avoid that. And then lastly, personal preference. We all have different preferences for products in certain areas. So I'm going to go over just a couple of technical videos in different areas of the face, and then we'll move, again, not show a lot of before and afters, but just talk a little bit about technique. Little nick here. All right, we're just going to blunt this lid cheek junction, putting a little bit of volume. We're just going to have to break through this retaining ligament. We're just laying a little depot after we get through the retaining ligament all across the orbital rim. So perpendicular to the orbital rim. The nice thing about cannulas is you can really see where you're going. You're not directly injecting on top of the field, so you can visualize everything that you've done. Obviously, it's a little bit less traumatic than a needle. Doesn't mean that you are completely safe from an intravascular. This is a little bit of her wider side. She's a little bit more deficient on this side. So we're going to go ahead and start on this side, and we'll blend the other side to match. The left side is going to require a little bit more volume, I think. I'm going to use a 25 gauge cannula. Little needle stick here. Her anterior malar is pretty good. So most of this is going to be over most projecting portion there. Now, because I'm injecting in the subcutaneous plane, I'm less worried about vascular injury, especially out here. I like cannulas for a number of different reasons. My incidence of bruising went down significantly when I switched over. But I like the fact that I can actually see what's happening as I'm injecting, which is hard to do when you're using single point needle injections. And again, I'm trying to not only increase the projection over that malar bone, but then also feather it up towards the apex of that area. I really want that volume to come up here, and then we'll transition in that submalar area. And there's a little bit more resistance down here because there's some ligaments that we have to kind of work through. Probably the safest place to inject is going to be right on top of the bone. So you can see there's no blood vessels here. And in general, we go about 1 centimeter above the lateral brow and 1 centimeter medial, all the way down to the bone. And that's where we lay our depot. So you can see here, this is a hollow area that can expand out nicely and help fill that temporal hollow that some of our patients have. And remember, the hair is going to come up to about right here. So really our goal is just to try to fill this area. So she has a bit of asymmetry, so we are going to inject probably about twice as much product on this side compared to the other side. So again, we're going to find our temporal fusion point, 1 centimeter up and 1 centimeter over, straight in the bone. Then I just stay in contact with the bone. You can see it's really not migrating anywhere. It's just expanding that and slowly diffusing. Again, temporal fusion point, 1 centimeter up, 1 centimeter over. See, there's a vein right there. We're going to this, go straight down. Okay, we're going to just add a little bit of volume to her upper orbit. She's fairly full laterally, so we're going to start more medially. And I like to use a cannula. We're going to go all the way medially here. Just layer just a little bit of volume here. Super periosteal. Make her a little bit more homogeneous across her upper orbit. It's a common place where people lose volume. The next thing we're going to do is really try to focus on the perioral area. Now, she would definitely benefit from some more aggressive treatment, hit some of these fine lines that she has, and then we'll soften her commissures as well as her nasolabial folds. And we're just going to kind of line chase here. What we're going to use is reconstituted Juvederm. We're going to reconstitute it with 0.5 cc's of 2% xylocaine to give us 12 milligrams per ml, which is very similar to their new product that they have out now. And you go to your lower lip here. And I'm using a 32 gauge needle to accomplish this. You want to be careful. You don't want to massage these too much because it can displace that product. Now what we're going to try to do is create a little bit of a pillar. We're just going to hold a little bit of pressure right there. And we're going to taper our injections again for volume along the red line. Try to create that little central lower lip cleft. Now she's got a reasonable volume in her upper lip. We're just going to try to create a little bit better definition. So there's a couple of different ways that you can do this. This will be one way that I'll show you. We're going to just come right in the midline, and we're just going to create a little bit of projection in an effort to give it a little bit. So that was kind of a whirlwind technical overview, but I think you saw that I use both cannulas and needles, just depending on where I'm going to be injecting. I do like cannulas for the reasons that are articulated. I think they're less traumatic. They're not necessarily going to eliminate the possibility of an intravascular injury, but they are less traumatic. But I still like needles in certain areas. I love needles for superficial injections, obviously. I love needles in the lips. So I think it just depends on the area. But I think cannulas are great. They're pretty inexpensive. They're going to be about $3 or $4 each use. And they come in all sorts of different lengths and sizes. I use a 25 gauge, either 1.5 or 2-inch cannula, just depending on where I am. So let's talk a little bit about ultrasound. I think this has been a wonderful tool that I've added over the last several years. I like it because I think it gives me good affirmation and confirmation of the underlying anatomy. I think if you are going to inject hyaluronidase, it's nice to be a little bit more precise with that. And it's, there is a learning curve like with anything, but I think it's pretty easy to incorporate into practice. For the face, we have a couple of ultrasounds in our practice. We have 7 megahertz that are really used primarily for breast and body. And then we have this 20 megahertz that we use primarily for the face. It gives you a maximum depth of about 4 centimeters. This system is actually nice because it's wireless and creates its own little network, so it's quite easy to use. One of the latest innovations that we have in injectables is really the incorporation of ultrasound. Now, ultrasound has been around for many decades, so it's not new, but I think using it as a tool has been fairly new. Injectors use it a number of different ways. I like to use it as an affirmation about where the underlying vascular anatomy is. So you can see here we're on her orbital rim. That's her infraorbital artery, more than likely there. We can see where her angular is, right on top of bone, right there, where we would expect it. The piriform is an area where you can inject either superficial or deep, and you can see that's where the angular is right there, right in the middle. So a deep or superficial injection would be safe. We're going to come down here. We can see the labial coming off the angular here, and see those labial vessels, and then I'm going to be moving towards the center, and you can see how they come more superficial. But again, in the planes that I'm going to be injecting, that should be very safe. We can do the same thing on the lower lip. Again, you see that nicely where the vessels are. And then lastly, if you are going to do an injection along the mandibular border, it's nice to know where your facial is, which you can see very well right there. It's fairly deep. So if I am going to do an injection, we're not going to do that in her because she's got a very strong jawline. I actually make this my access point right over the vessel, and then I'm going to be going deep away. So that's going to be a very safe plane for me. So again, it's something that you can nicely see. The other benefit, and we'll talk about this, is really helping guide the injection of hyaluronidase to help eliminate filler. It's much more. We're going to show you kind of a neat little software upgrade for this device. It's called the T mode. So when you're just starting ultrasound and you look at an image like this, you may be a little bit confused. What we can do is go to our applications, and for this one, we're going to pick cheek. And then you can come down here and hit T mode. And then go back to your scan, hit pause, and it can kind of roughly tell you what you're seeing. So you can see that just kind of labels things, and it's a little bit embellished, but I think that's fairly accurate. You can see the subcutaneous fat, the deep fat, and then the SMAS in between. And then you can even go to a structure like the lip. And again, go back down to T mode. It's interesting because I think that it kind of misreads or mislabels that superficial muscle and labels it as subcutaneous tissue. But I think as you're starting. So just yeah, so just as you start to bring ultrasound into the practice, I just kept it in the office and I used it on every patient. I think, whether you're using it for face, breast, or body, if you use it every day, you become very familiar with it. And now I don't use it on every patient. It really just depends on where I'm going to inject. If I'm going to do a piriform aperture injection, I always use it because I want to know exactly where that vessel is. I like to use it in the lips, certainly the temple area if I'm going to inject there. If I'm going to dermal line chase in the forehead, I really want to know the course of both the supratrochlear and the supraorbital nerves. So this is actually up in the glabella forehead area. So I'm getting ready to do some dermal line chasing, and I'm just trying to follow the pathway of those supratrochlear vessels to see exactly where they are. And again, we're going to be injecting in the dermis, so we're well above those, but it's just nice to have that affirmation. And again, this is just a static image of that. So let's just take a look at where we've injected. This is her right cheek, and you can see that product, those little darker spaces through there is going to be the product. So again, it's largely subcutaneous. That's masseter muscle that down below. Same thing on the other side. That's our product, pretty evenly distributed throughout there. Let's go a little bit more superficial here. It's a little harder to see in the dermis because this is largely, the nasolabial fold's largely a dermal injection. We're just going to take a peek at our lips. So this is lateral lip there. You can see a little bit of product coming through. Here's the center, little central bolus there. Here's upper lip. You can see our product. It's above where the vessels are. So let's just take a look at where we've injected. And then as we had mentioned, I think using it for hyaluronidase injections, you can see here's my needle coming in and it's very specific and precise. So it's nice to bring the ultrasound in after you do the injections, just to start to familiarize yourself with what the products look like. I mean, obviously with hyaluronic acid products, you're going to see that hypoechoic area. And again, you can nicely treat areas of irregularities with hyaluronidase under direct guidance. And I think what you find is that you need less hyaluronidase over time, and it's just more precise. Now, I've not had to use the ultrasound for an intra-arterial injection, but certainly I know a few people that have done that, and it's really helped with recovery for many of these patients with this intravascular injuries. So again, it's easy to use. It confirms the anatomy. I think it is a little bit cumbersome. I know some injectors use it to guide their injections. I really use my non-dominant hand quite a bit. So I think when I try to use the ultrasound to do my injections, as opposed to what they do in orthopedics where they're just giving a shot, I find it a little bit harder to use it, except for when I'm injecting hyaluronidase. This was kind of an interesting device that's coming out. Ben Asher developed it. We saw it in Paris at MCAS, but it's a fingertip ultrasound, and it's really, I think it's a 15 megahertz, and it's got color Doppler mode and everything. So this may allow you to use that non-dominant hand a little bit easier when you are doing injections. So I don't have one. I've not used it, but I was kind of intrigued by this. So what about injecting hyaluronidase under ultrasound guidance? This was a study that was published in ASJ a couple of years ago, and they had this 39 patient cohort that was initially treated by the way we taught. You're going to flood an area once an hour with roughly 500 to 1,500 units, just depending. And what they saw, at least based on ultrasound, that there was less than a 10% improvement in that cohort. They took the same patients, went back secondarily with ultrasound, and then use that precisely to the space, and they saw 100% improvement with about 10% of the product that was needed, the hyaluronidase. So that was cool. The other thing that was kind of neat in the article was they, initially there was just a paucity of blood flow through the major vessels in the area. And as they started to inject the hyaluronidase, they start to see color return of the vasculature in there, which was consistent with what they saw clinically as well with resolution in these areas. So again, I think using ultrasound to specifically guide you to treat problematic areas and certainly intravascular injuries would be, I think, very helpful and prudent. So I want to talk to you a little bit about this 10-year review that we did. And really the goal was just to kind of assess where our practice, my specific practice, and I'm in an academic practice, has evolved over the last 10 years. And so we use CPT codes to go back and manually, retrospectively try to harbor these patients. And again, there's some inherent problems with doing it that way, but so take it for what it's worth. So these are kind of our numbers over the that 10-year period. We were doing somewhere around 400 botulinum toxin injections and then doing a couple of hundred fillers. And, part of it's the demographic of my practice. You can see the majority of the patients that I see do one or the other, and only about 20% actually did a combination. I think that's probably changed over the last 5 or 6 years, but like I was kind of surprised by that because I thought that I was doing a bit more of combined treatment. I think half of our patients take advantage of some type of discount. Once or twice a month, I have an injection clinic where I offer 10% off. And so half of our patients are actually looking at that and coming in for those. And then you can just look at how much each patient spent and whether that translated into surgery as well. So the majority of our patients got Botox. When the other products came out, we certainly used them. And I would say about 10% of our patients prefer ABO, botulinum toxin. And then we have a few patients that also like the Daxi product. We don't currently use the Inco product in our practice. The most common area that was injected, to no surprise, was the glabella, followed by the crow's feet area, and then the forehead. And then you can just see all the other areas that we've injected. Lips would probably be the fourth most common area that we injected. And then if you look at the fillers, I think you can see that, again, most of the products are represented. A couple of them are preferred, mainly because of the areas that we're treating. The most common area that we treat is really the commissures and the marionette lines, followed by the nasolabial fold, and then the cheeks and lips. So you can just see the products are really just dependent on what areas we're injecting. So let's talk a little bit about complications. It's always humbling to look at your complications. So I'll show you some of mine and some of the ones that I've seen. This is a patient of mine who it was one of the first times I did supraorbital injections just to try to help with that A-frame deformity. And you can see I just got a little carried away and put too much product in. Fortunately, with a little bit of massage, we were able to take care of this and didn't even need any hyaluronidase. But again, that's only going to be about a 0.2 to 0.5 ml of product per side. So you don't want to go overboard. Tyndall is something that really can happen with any product, and that's what I've learned over the years. It's not specific to one product over another product. It can almost happen with any, and so you can see here in that right corner of the mouth, that Tyndall, probably from a real superficial injection, which is where I tend to inject it, and then how it responded to hyaluronidase. This is a patient that was referred in. She had some temple injections and then some forehead line injections and had some irregularities. Fortunately, these were largely hyaluronic acid products, and they were pretty amenable to treatment. What about eyelid ptosis? I mean, I think it's fortunately rare, but if you look at the pivotal studies for all of the products, the incidence is somewhere between, less than 0.5% up to about 3%. Depending on what studies that you read. Here's the Dysport clinical trials as well, roughly about the same thing. So when I went back and looked, I had 3 cases of eyelid ptosis, so my incidence was about 1 in 2,000. Interestingly enough, my first patient was about 17 years after I started doing the injections. So it was back in March of 2019. So you can see here, left eyelid is ptotic. And then, so we, recommended some alpha agonists for a month or so, and then she recovered from that. A couple of months later, this is an old patient of mine who I did just glabellar and lateral orbital injections, and she developed it too on the left side as well. So that gets you starting to think, well, why I've seen two patients recently. Why am I getting it on just the left side? I do prefer to do all of my injections from the patient's right side. Maybe I'm reaching over a little bit too much, and that product is either diffusing or being displaced downward into the levator. I did well until a couple of years later, and I had this patient who, of course, it's always your family and your friends that get it. And again, this was the one that really convinced me that I needed to make a change. And so now I either go to the other side or just turn their head more towards me to try to prevent that from happening. And again, it's a little alarming for patients. And even though you can get about 1 or 2 millimeters with alpha agonists of elevation, it is something that is a little alarming for them. Now, brow ptosis is a little bit differently. We try to recognize the patients that are going to be at high risk, certainly the animators, those with deep lines, but those are also the patients that want those lines to be improved. So yeah, so this is a young person that I injected, and you can see why I think the shape of her brows are better. They are lower, and so her mascara ran onto her upper lids, and that's what she didn't really like. This is a different product. Again, I think this patient's better balanced with her filler and her toxins. But again, she felt like her upper lids were a little bit heavier. You could make an argument that they look more youthful, a little bit lower and a little bit fuller, but again, something that she noted. And then this is with Inco, same kind of thing. Animator had things come down. So you can do a couple of things. If you have animators, you can just avoid that first couple centimeters above the brow. I've kind of transitioned into just doing some small amounts of dermal injections. My incidence of brow ptosis is significantly less with a small amount of dermal injections, and it does seem to diffuse and help the lines in that area. What about adverse events with soft tissue fillers? Well, there's a litany of adverse events that have been published. I've had my fair share, and I think these are way underreported by patients because most of them don't come back or let you know unless it's a significant problem. So I want to just share with you a couple of cases because these were kind of memorable for me. This first case is a patient who underwent filler injections to her cheeks, and she noted a lump kind of early on, but didn't really pay attention to it. And then came back in about 10 days after her procedure with some localized swelling and inflammation and certainly sensitivity. So I aspirated it and cultured it and then injected hyaluronidase, and I started her on antibiotics. She really struggled with antibiotics, to be honest with you. And I wasn't sure how compliant she was, but she grew out mycobacterium that was fairly resistant. And so I got ID involved, and they actually recommended excising the whole area, but she really didn't want to do that. So I taught her how to take an 18 gauge needle every day and poke the area and squeeze it. And so she did that for a month, and she cured herself. So that was pretty impressive. And then ultimately, once she had completely healed, I brought her back a couple of times to put some fat in that area because she did have some fat loss where she had her infection. And this is what she looked like. This is how she presented. And then shortly after she had healed. And then this was a couple of months later, a patient who had about 28 days out from her soft tissue injections to her cheeks, had a similar presentation, although not quite as dramatic, did the same thing, started her on antibiotics, and I suspected mycobacterium, which we never grew. I think that the concern for me personally was this happened within a month of the last case. And so we have about 16 providers that see patients. And then I went back, started talking to everyone, and we had some breast implant infections that were mycobacterial. So we actually had ID and an outside company come in, and what they found was that the mycobacterium was living in our ice supply. So it's usually in areas where there's a lot of construction. It can be in your ice. It can be in your air conditioning ducts or what have you. So that really changed the way I practice. I used to put ice directly onto the skin, and now if we use ice, I put it into a glove or something like that, or we have ice rollers. And really, fortunately, knock on wood, I haven't had another case like that. But this is that patient's presentation. So much less dramatic than the first one. And here's a lady that was referred in. She had 2 infections in her cheeks following soft tissue filler. And then I wound up just treating her with fat grafting. You know, you had a limited amount that you could put in each time. So she wound up having 5 procedures, but we were able to correct that after that number of procedures. So then, of course, she wanted more filler. And so I did it. And she developed a localized infection. So some patients, I guess, are just not meant to have fillers or injectables for sure. So like with anything, bruising can occur. This is a pretty bad bruise, and I don't see a bruise like this very often anymore. When I was using needles around the orbit, I tended to see these kind of things. But, you know, if a patient gets this kind of bruise, it's going to be a long road to recovery, and they might even get some hemosiderin and deposits in that area. So we have a vascular laser, a 532 wavelength that we actually use to treat bruising, which is kind of nice. Or you can even use intense pulse light. And we don't know exactly how it works. It probably dissipates the hemoglobin in the tissues and then allows the body to digest it and help make it go away. So again, just I've had a few nodules and palpability. I think, again, way underreported, I'm sure, because most patients aren't going to come back for those kind of things. This is a younger patient who I did a little tear trough injections, and when she's a big animator, and when she smiled, she felt like she had a little bit of fullness kind of in this area right here. And usually if a patient has something like that, you can instruct them how to manually massage that area. You rarely need hyaluronic acid in this area, but occasionally you do. This is a patient who developed some localized swelling kind of in this cheek area afterwards. It's hard to know why. Is it related to the G prime or how you inject the product? Certainly larger volumes increase the biofilm risk. You know, just over time, this tended to get better, but I think there are just some patients that are just prone to developing edema, sometimes short term, but others potentially long-term edema. So again, you have to remember the higher G prime products, which we tend to be injecting deeper, are going to be more subjected to technique. Rapid injections are going to cause shear and higher pressure, which can create more edema and inflammation. So you need to be mindful of that, especially with the higher G prime products. And obviously, the Juvederm products, and specifically Juvederm Ultra, is the most hydrophilic product that's available. So, you know, in a lot of ways, swelling can be beneficial, except when you're around the orbit. So you want to be careful that those products that are extremely hydrophilic, you kind of avoid the area around the orbit, because I think it tends to retain fluid in that area. And even free hyaluronic acid can exist longer in that environment compared to other environments. There's not been a lot published on chronic eyelid edema following filler. This is a paper in ophthalmology literature. I know we hear it occasionally at meetings. People are using all sorts of things to try to improve that, but it can be a real struggle to improve it in these patients. And you know, Mark Ashton and his group, including Ian Taylor down in Melbourne, have done a lot of great anatomic studies. This was a great paper in PRS where they really just highlighted lymphatic drainage around the orbit. Obviously, there's a medial drainage along the nasolabial fold, and then laterally, there's drainage that goes ultimately to the parotid lymph nodes. So you can imagine a situation where you're injecting all these different areas, and if you have a patient who's prone to developing edema, doesn't have a real good lymphatic system, the edema may persist. And I think like this is a patient who had hyaluronic acid injections about 7 months prior to us seeing her, but she fell and developed some soft tissue trauma and then wound up with some persistent edema because of that. So perhaps the filler had an impact on the lymphatic channels, but it wasn't clinically relevant until she had more trauma, which made it worse. So again, it's hard to know what to do with these kind of patients, other than I send them for lymphatic massage and really try to do what we can to make sure all the product is gone. But it could be a challenge. Now, what about vascular injury? So this is fortunately my only case of vascular injury. I was doing dermal lines in her forehead, and she called the office probably about an hour later and said she was having pain. So that is really something that you have to educate the people that answer the phones, because in a surgical practice, patients have pain. I mean, I think it's just part of normal recovery. But if an injectable patient calls and is having pain, they need to be seen immediately because there's something wrong. And clearly there was a watershed area that was treated. So we brought her in, and I did a series. This was back before we really had ultrasound. I did a series of injections with hyaluronidase on her, and ultimately she healed fine, fortunately. She really didn't want to stay in the office all day, so I think she stayed about 4 hours. So I did 4 rounds of injections, and then she came the next day, and fortunately she was fine. This is a guy we saw in the ER. They injected his nasolabial folds in the community here, and then sent him for further treatment because he had this kind of vascular compromise. And so we flooded not only his nasolabial fold but his nasal area with about 1,500 units every hour for about 7 courses, and he got better. Fortunately, again, before I had an ultrasound, now I would have gone right in specifically with the ultrasound, found where that product is, and injected directly. And I probably would have been able to resolve this much quicker and use a lot less product. So as far as complication prevention, obviously you need to be familiar with the anatomy, but anatomy isn't always consistent, right? So I remember the first time I used ultrasound, I was doing a piriform aperture injection, and I almost always go deep onto the bone or inject in the skin. And so I did the ultrasound, and sure enough, the vasculature, the angular, was right on the bone. So if I would have done a deep injection, that would have put me at a higher risk for having a vascular injury. Obviously, you want to do slow, small volumes and constantly moving. Intraarterial injections are more common when the needle is passed parallel to the known branches rather than perpendicular. I think cannulas do help decrease the risk for bruising. Not going to necessarily eliminate the need for, or excuse me, eliminate the possibility of an intravascular injury, but it should decrease it. And I think anybody who's had prior surgery or you're injecting in a scarred area, you just need to be very careful because that anatomy is not normal and potentially you can have a problem there. So I use hyaluronic acid products. I feel like they're safe, somewhat reversible, and low risk. I don't use any of the biostimulator products. I think we all have opinions about the impact that those have on surgery, but I just don't like not having control, and I feel like I don't have control when I use those products. And again, ultrasound, it's fairly inexpensive, and I think it's a nice thing to bring into the practice. Actually, patients love it. They love the fact that you're confirming things. I see so many patients because I'm one of the few people that do ultrasound in Dallas. So I see a lot of patients not only for complication prevention, but just I think it's reassuring to them that we're looking at their anatomy before we do the injections. So injectables are super important in my practice. I do them myself. I have no problem with using an extender. I just enjoy it, and it's probably better for me because I'm in an academic practice. I love the artistic nature of injectables. Plus, it's an opportunity to dialogue with patients, answer questions that they might have about perhaps other procedures. It's a fairly low complication rate, but I inject the patients and I see them in follow-up. I think it keeps our patients cycling in the practice between the injectables as well as our estheticians. They stay in our practice and then ultimately go on to have surgery or what have you. I think small discounts increase accessibility, and I think it creates long-term investors. The other thing, when you have an injection day, it just streamlines patient care. They're in and out a lot faster. It's so much easier for the nurses because everything's there and everything's ready. So that's been very practical for us, and it's worked really well. And with that, I will stop and certainly happy to answer any questions should anybody have any.
Well, thanks, Jeff. That was amazing. I find that when people show their complications as opposed to their before and afters with the best success they've ever had, that people learn so much more. And I think a lot of doctors would probably agree. So thanks for doing that. We really appreciate it.
Sure.
Speaking of ultrasound, and we'll wait for everyone to put their questions in the chat box. We're going to run a few polls, so we'll appreciate you participating in those. But Were you an early adopter of ultrasound, or did it take you a while? I mean,
No,
the only
I
one.
really
Yeah.
wasn't. I don't do body contouring, BBLs and stuff, but I learned so much from like Pat and watching him embrace ultrasound, and then it seems so simple. And then like Chris Zurich and others were starting to use it, and it just kind of made sense. I didn't want to use it in every case, and I didn't want to use it to actually do the injections, but I think the more I used it, the more comfortable I got with where the anatomy was. And I think, as I said, it's just good affirmation in certain areas like the lips, temple, alar bases, or whatnot. So, and it's very inexpensive to bring it into the practice, and it should last you for a decade easily. So,
That's great. Now, why are so few people using Daxi, and do your patients come in asking for toxins by name or just give me Botox?
well, I'll just share with my experience. I don't have any interest in any of the companies. I think I read the Daxi studies, and I was excited about it. I think patients were excited about the potential to have a product that's going to last twice as long, at least in the glabella. And the studies were pretty clear. About 50% of patients had a 6-month improvement. 50% didn't have quite that. So when Daxi came out, we had it in the practice, and I think almost all my patients tried it, but we just didn't have that kind of success in our practice. And again, I'm not blaming the product. That just in my hands, I think only about 10 or 15% of the patients really had the longevity that we were anticipating. So again, I've been a little frustrated with not being able to achieve a longer result for the cost. And
Yeah,
so
for sure.
I think people are very comfortable with the other toxins that are out. They know what they can do. They have expectations. And yeah, it means that 2 extra visits during the course of a year, but the predictability is really important.
Excellent. Thank you. So how are you staying updated? All of these emerging technologies, devices, how are you getting your information?
Yeah, I think it's you go to meetings, you know who the kind of key people are, you see presentations, you certainly read publications in our journals, and I like a lot of non-surgical things, including devices and injections, so I'm kind of tuned into that world. But the most important thing is looking for evidence-based medicine. You can't really use subjectivity, or a company will come in and show you 3 before and afters and say, hey, this is a great $200,000 device, you should buy it. It's like, no, I'm not going to make those kind of decisions. So I have high standards for myself, but also for any um, tool that I'm going to bring into the practice. So I'm not going to be the first one with it. I won't be the last, but I need to see the data, or actually have some experience with it.
You're definitely a data guy. We all know that.
Yeah.
Now, can you talk a little more about when the ID team came in to look at the bacteria?
Yeah.
How long did that take? Was there downtime?
Yeah.
What was the process?
It was scary, to be honest with you, because I had 2 patients myself in a month, and then we had, I think, about 5 or 6 mycobacterial breast infections. Granted, we have a big practice and we see a lot of patients, but that's just not normal. So that process took us, because the problem with mycobacterium is it's fairly slow going. So cultures can take sometimes a couple of months. So I think the whole process was a couple of months, 2 or 3 months, by time we were able to isolate where it was coming from. But there's so much construction around where I work, and you keep reading about it can be in the water and things like that. I've heard that it can be in your ice machines, but I never anticipated that it would have been. And as I said, we changed our practice after that. I stopped using ice directly on the skin.
Yeah.
Really made it it's not a true sterile procedure, but we try to make it as sterile as we can. We use Hibiclens or chlorhexidine, prep, let it sit, use appropriate gloves, and then either use an ice roller or ice within a glove.
Fantastic. It looks like we've got a question coming in from Stream Nivasa. If you want to unmute yourself and ask your question, please go ahead.
Yes, Jeff, thank you very much for a nice lecture. It
Sure.
was informative and we routinely do a lot of fillers in Saudi Arabia. I'm in Saudi Arabia, Jeddah. Okay, I have two questions. One
Okay.
question is, what is the limitation of the total volume of the filler inject in the face?
What was the total volume?
Yeah, right.
It depends on each patient. I don't put tons of product in patients. My patients are probably a little bit more economically sensitive. So, the lips, I don't use more than a syringe of product. Each cheek will use a half to 1 cc of product, as far as fillers. So I'm pretty conservative. I'd rather undertreat and have them come back. And I think most of the patients that I see feel the same way. A lot just depends on the area that you're injecting. If I want global improvement in the cheek, I may reconstitute the product a little bit and inject it in the subcutaneous plane, not only in the malar area, but in the submalar area. And I think I tried to show that in that one video. So it's pretty variable, I would say.
Okay, usually I am putting 7 to 10 fillers per patient
Wow.
sometimes. Yeah,
Wow.
that's what I asked the question.
Yeah, that's a
And
lot.
mostly I inject the cannulas for injecting in the cheeks and in the zygomatic hollow and in the jawline near the angula of the mandible.
Yeah.
The angula of the mandible I inject the deep over the bone. Then I taper it like angulation, and I fill the gap at the sulcus in the myriad sulcus.
Yeah, well, that's great. I mean, the products are all wonderful, and I think it's you can use cannulas in most of those areas. I think it's nice if you had an ultrasound, there's a few areas that you would probably want to check and make sure that you're well away from those kind of higher risk areas, which I think I tried to highlight in the video.
Yeah, that's true. What are the product you are injecting in the lips? I am using injecting Juvederm Volbella for the lips and
Yeah,
Valium for the cheeks.
there's so many products that are out now that are approved for the lips. I mean, Volbella is certainly one of them. Um, you know, uh, Restylane Kiss. I like RH2 in the lips as well. So it's probably usually one of those three products that I inject primarily in the lips.
Thank you, doctor,
Yeah,
for the
thank you.
question.
Thank you
Appreciate
so
it.
much.
Yeah.
So Jeff, we've been running some polls, and I had asked, when was your most recent purchase of your newest product in this space? And 20% said less than 6 months they purchased something, 40% said 12 months or more, and another 40% said more than 2 years. How often are you buying new devices for your practice?
Well, devices, I would say it just depends. Most of the devices that we buy are actively used in our practice. So probably at least every other year. It's a little bit more of a process being at the university to purchase a device. I think with injectable products, I love to try new products. So when new product come out, it's nice to try them. But we keep a fair amount of product on board because we have about 3 or 4 providers that use it almost every day. But we made a mistake and we made a shift in our practice and we're using a different product and then wound up with 18 boxes of a
You
product
said,
that now is going to be expired. And that's not an insignificant amount of revenue lost with that. So I think there's probably better ways to do it than what we did with that. I mean, that doesn't happen very often, but it can, especially if you try a new product and you really like it, and then you had already just ordered all that other stuff. So
okay,
um, it can be a little bit of a challenge. So you have to watch the economics of it.
for sure. Do you think that's the same in private practice? That in terms of product and devices, are they buying them on average every year or so, or does a smaller, maybe more nimble, non-academic practice have a little bit more bandwidth to test
Well,
things?
I think, we all are encouraged to buy more product because it's cheaper, right? So you want those discounts and things. And so, but there's a balance, right? You have to know, I mean, if you're in private practice and you're the only provider, or if you have an injector and they're the only provider, you really have to follow your inventory closely and see what products are being used the most. And then keeping those up to date. But I think if you get ahead of yourself too much, then you can find a situation that, like I said, that we just had, where you wind up losing a fair amount of money.
Where you've got an overflow, yeah, for
Yeah.
sure. So, toggling back over to kind of new innovations and developing techniques and devices and products, um, is there a certain demographic that you find these new products work better on? Whether it's, I mean, I won't even kind of say, I'll just say, what demographic do you find is maybe most receptive to the newer products?
Well, I mean, I think, the companies are smart. They don't advertise to us, they advertise to the consumer, right? So you have direct to consumer advertising, which creates this idea or thought by patients that they need this, and so they come in and asking for it. So not only do you need to keep up with evidence-based medicine, but you kind of need to know what is being advertised on TV or in some of the magazines that your patients read.
Mhm.
As far as which patients benefit the most from like fillers, I mean, I think there's more limitations to what fillers can do in a more older, deflated face with poor skin.
Mhm.
I think there is, you know, the younger generation, those in their 30s and early 40s, have been kind of raised in an era where this is the norm now. So it's part of their prevention of aging, their prejuvenation, whatever you want to call it. Using products is just part of the norm now. So
Like
my
skin.
demographic has changed a bit. Like, I know the limitations that I have in an older patient, and where I can get an unhappy patient because they just don't achieve the outcome. And those patients, you talk about surgery, and the most of them don't want to have surgery, but at least they can walk out the door and I can look at myself in the mirror and feel good about it. But it's
Yeah.
the younger patients, that are really embracing. And it's not only the toxins, it's also the fillers as they need it. And so I think, I don't know what's going to happen in 30 years. I don't know what the impact of these products are going to be. Is it going to preserve their appearance and their volume? Is it going to have an impact on stretching the skin out? I mean, I think as long as the distortion is minimized, and that there's not these absurd, crazy silhouettes being created, I don't think it should have a huge impact on the skin long term. But it's a spectrum of age groups that we see for sure.
Understood. So let's pivot over to exosomes. When you and I were in Paris during the IMCAS meeting a few months ago, I think we were walking the exhibit hall floor and really amazed and astounded by how many companies and products were, kind of on the exosome bandwagon, if you will. So what do you feel is the general understanding about exosomes? Where do you see it going? I know we've got a project on ASJ that's a supplement that's in progress. But what's this world all about?
Yeah, I wish I could tell you I have a clear understanding, but I don't. But I am excited about it because I think it is the future. If you look and remember stems, where we were with stem cells 10 or 15 years ago, it was like going to be the magic bullet, right? If we were going to be able to do all this great stuff with stem cells. And that's just, I mean, it's happened to some degree, but it really, I think, has been limited because how challenging stem cells are to harvest, and what will the FDA let you do and what won't they let you do. Whereas exosomes, it's a totally different thing. I mean, these are very specific DNA sequencing proteins that can be applied topically. They can also be injected as well. There's human-based, there's animal-based, there's plant-based, and even the plant-based ones have some similarities with human sequencing. So again, we don't have a lot of objective data in this area, but I feel like this is going to be easier to grab and bring into the practice. And I think it's going to have a much more rapid impact on things long term than when we're still waiting for the stem cell stuff. So
Sure.
I think we're going to just see an onrush. I think, you brought up Paris. I think there were a couple hundred companies there that were promoting exosomes, and we're going to just see more and more of those. And I think we're going to have to figure out what is going to be the best. And it may not be only human. I mean, some of these other products that are animal-based or plant-based may still be very effective. So I think we're going to learn a lot over the next year or two. Certainly, the supplement, we hope, will be a good starting point for people to start to learn more about exosomes and how to bring them into practice. I'm sure a lot of people on the call already have brought them into the practice. There's many skincare products now that are incorporating exosomes. And it's not just for cosmetic reasons. There's, reconstructive reasons that people are using them.
Yeah, and I know we've probably published on in ASJ on exosomes. I feel like this is an area where certain people are kind of rising to the top as the kind of resident experts, as happens, right? And when there's new things happening. So you and I have been working with Steve Cohen and Diane Duncan and a few other people. So it's definitely something to keep our eyes on, something that's interesting. I hope the patients will be receptive, and obviously there'll be some kind of an educational learning curve to make sure they understand, so we can all get a handle on it first, and then explain it to our patients. So with that, I'll see if there's any final questions before we end for the day. And we have a journal club coming up in a couple of weeks. We'll be sending out more information about that. But any final closing thoughts, Dr. Kenkel?
No, I think it's great that you all were on. I don't know if I shared anything too novel, but I do like the concept of ultrasound and continue to try to use it and get better with it. And, I think we'll see some technological advances with that tool that may make it a little bit easier to embrace it in these types of settings. And
Fantastic.
so
Well,
much
thanks for
having me.
sharing your expertise with us. And as always, we look forward to what comes next and having you on with us again. And have a great rest of your day. And thanks everyone for
Great.
joining
Thanks,
us.
everybody. Have a good weekend.